Good evening to all of you. Today, on behalf of Johnson & Johnson, we would like to welcome you all on our case-based webinar on recent advances in shoulder surgery. And today we are having Dr. Rajat Jangir, who is a consultant and orthopedic and director based at Mahatma Gandhi Hospital. He is also the professor and head of Mahatma Gandhi Hospital in the Department of Sport Medicine, Jaipur. Dr. Rajat Jangir is having a vast experience, and he is also part of various organizing committee like Indian Arthroscopy Society, Indian Cartilage Society, and many more. Dr. Rajat Jangir has won various awards like Best Reviewer Award in the Journal of Orthopedic Case Report 2017, Best Publication Award for Delhi Orthopedic Association, DOACON 2017. He is also the editorial board member of Journal of Indian Arthroscopy Society and Journal of Orthopedic and Bone Disorders for Medwin Publishers. And at the same time, he has been part of various forums and various other symposiums in the last 5-6 years. Dr. Rajat Jangir has been also been part of Rio Olympic in the year 2016 as the sports medicine doctor. So today we are very much thrilled to have Dr. Rajat Jangir with us, and he is expert in this field. So without wasting much time, I will be handing over the session to the doctor, and the Q&A that we will be having, we will be taking at the end. So Dr. Rajat Jangir, over to you, sir.
Thank you, Diptam, for that kind introduction. So I'm Dr. Rajat, and basically I'm a shoulder and knee surgeon, and I will be speaking on recent advances in shoulder surgery. So this is not going to be like a theory lecture. This is going to be a practical case-based discussion, and we can take question and answers after the session. So I did my education from BJ Medical College, Ahmedabad. Then I did my shoulder arthroscopy fellowship with Professor Emilio Calvo from Spain, and also my knee arthroscopy fellowship from South Korea with Professor Juno Bong. So that was my initial teaching, and later on I decided to do my practice. And so there are so many common shoulder problems, and if I divide them, they are quite common in young patient and elderly patient. So in young patients, there are few specific problems like shoulder dislocation. So young patient, they are physically active, and they may also have a road traffic accident. So shoulder dislocation is quite common in them. There are some athletes and sports person, especially the volleyball players, those requires the overhead activity. They are very likely to get the slap tears, and those similar patients also get the impingement, and this is typically a posterior superior impingement. And another thing is the biceps tendinitis, that is inflammation around the biceps tendon. And being physically active, they are also likely to get more of fractures. So these are quite common entities around the shoulder in young patients. In elderly patient, if we compare to the young patients, the diagnoses are quite different. We see more often the rotator cuff impingement thing. First, they start with the rotator cuff dysfunction, then the impingement. Later on, it converts to a rotator cuff tear. Primary shoulder arthritis is also a common entity in elderly, and the rotator cuff tear, they might convert into a rotator cuff arthropathy in those patients. So the diagnosis quite varies in young and the elderly patient. Young, if I say the less than 35 to 40 age group, and elderly, I say 55 to 60, more than that. So we'll take one by one all of these things which are common around shoulder. In young patient, if we start, it is the shoulder dislocation, which is quite common, and it is quite recurrent because the elderly people, they may get a shoulder dislocation, but it is not recurrent in those patients. Why shoulder dislocation is quite common? Because the shoulder is the most mobile joint in the body, and this mobility comes at the cost of stability. So in any activity which have this abduction and external rotation, So in those activities, this abduction external rotation, there might be an injury and it may push the head antero-inferiorly. So this leads to a typical lesion, that is the Bankart lesion. So that Bankart lesion is the peeling off of the antero-inferior labrum due to push by the head. And also when this head strikes against the glenoid, it produces a posterior-superior bony defect. That defect is known as a Hill-Sachs lesion. So to diagnose these patients, we often need an MRI. An MRI will typically demonstrate the antero-inferior Bankart lesion and the Hill-Sachs lesion. So in these patients, what we do is the arthroscopic Bankart repair. So this is typically done in this lateral position. So this is the examination under general anesthesia, and this is done typically with 3 portals. So this is one is viewing portal, and there are 2 instrument portals. So through which we would do the surgery. What is the advantage of these 3 portals? Only that there is going to be a faster recovery because there is less of bleeding, less of soft tissue trauma, less of post-operative pain. So this leads to a faster recovery. So this is the arthroscopic view. This is on the one side. You can see here, this is the glenoid part, and here comes the labrum, but there is no labrum here. And this is the capsule. So labrum with the capsule is avulsed or separated from the glenoid. So this is arthroscopic view. This is glenoid. This is capsule and a labrum. There is almost no labrum. So with those 2 instrument portal, we are viewing from the superior portal, and with the other portals, we do this surgery that is known as the Bankart repair arthroscopic surgery. And we place, here is the cartilage and there is a bone. We place a anchor here, and with the sutures we repair this capsule and produce a bumper. So there is no antero-inferior dislocation. So this is one patient after the 3 months of the surgery. So after the surgery, he underwent the regular rehabilitation or the physiotherapy, and after 3 months, he is able to play the volleyball again. So this is another case scenario. That was the antero-inferior dislocation, and this is the posterior shoulder dislocation. So this patient is a boxer, national level boxer, and he had some trauma. He was hit from backside by someone during a fight, and he developed a posterior dislocation. But he also had this problem that he made it habitual. So this was a posterior inferior dislocation, which he incidentally later on made habitual. So he was able to dislocate this shoulder. So in this video, you can see that he is able to dislocate his shoulder posteriorly. And this was also the cause of pain around the shoulder, because he later on developed this scapular disc kinesia, because that is the muscle dysfunction around the shoulder. So this was his arthroscopic picture. So you can see the labrum, the posterior inferior labrum is torn, and there is also an separation from the cartilage. This was also repaired back with the help of those anchor sutures, similar to that has been shown in the previous video. So this is the result after 6 months. So he was able to play the boxing again, and there was no pain. So relieved from the habitual dislocations, and also relieved from the pain which he was suffering from the recurrent dislocation, that is the habitual plus the posterior inferior instability. Another very common problem in the shoulder to the overhead athletes, that is volleyball, baseball pitchers, and badminton smashers. So in these patients is a quite common scenario, that is the slap tear. So here in the middle picture, you can see the biceps tendon, the long head of biceps attaches to the superior labrum. So due to the excessive demand of external rotation, because these patients require excessive external rotation to get the force during the cocking phase. So there is compensatory reduction in the internal rotation that leads to the posterior superior impingement as well as excessive force on the labrum. So this leads to a tear here. The biceps attached to the superior labrum, there is a tear here that is known as a superior labrum anterior to posterior tear. So there is a tear in the superior labrum. In this video, you can see the arthroscopic picture. This is the labrum and this is the biceps, and you can see a superior labrum anterior to posterior type of tear. So these patients also require investigation, that is the MRI. Sometime we may not be able to diagnose it on MRI, and we may require an MR arthrography. So we can see the labrum tear, and on arthroscopic biceps stenodesis, this is the procedure which we could do in these patients, especially for athletes. If it is a non-athlete, we can do slap repair, but for the athlete people, we always prefer a biceps stenodesis because it produces the long term and back to sports. So this is the video of the patient after 3 months. He is able to throw the ball again. So they always have a problem in throwing, and after the surgery, the 3 months of the continuous rehabilitation, he is able to throw the things again without any pain. Another very common entity is the biceps tendonitis. So here the problem is not in the intra-articular portion, it is in the groove, the biceps groove. So there is an inflammation around this tendon here, and the patient may feel pain and weakness around the shoulder, especially those overhead athletes. Diagnosis can be done with an MRI, USG. Essentially, these patients are initially managed conservatively for at least 2-3 months with all the pain modalities. Some patients may require a USG guided steroid injections. If the physical therapy is not effective, that means that it is refractory to the treatment, then we may require again the biceps tendinodesis. So here in the slap tear, here is the problem. So we do a biceps tendinodesis here, that is known as a intra-articular above this groove, the biceps tendinodesis. If there is a problem here in biceps tendonitis, we do a subpectoral below the pectoralis major muscle. So this is a subpectoral tendinodesis. This is again a very rewarding surgery. So all these surgery, minimal invasive, the arthroscopic surgery, what is the advantage? The advantage is very minimal